Really humbled to be here today. As many of you know, this is pretty much my last swan song. I will be leaving Sentara next Friday to be honest, to move to Colorado. And so very excited about future. But one of the biggest things that I didn't know a lot about before I came here that has truly been one of the best things that I was part of was EVMS and the relationship that we created between Sentara, EVMS, all that went on. Some of you might hate me for that. Having said that, it is truly something that to me is, and I tend to be at the highest level looking down, is truly something unremarkable, is remarkable. And so I need to thank you for being part of that. Without all of you, we could not do what we have done in this community to take care of people in new and creative ways. And so what I was asked to do today is, and by the way, I do feel free to ask me questions during my presentation. If I don't answer them, it's not because I'm ignoring you. I just didn't like the question, okay? And if it's too hard a question, I'll say, that's such an easy question. Dr. Hooper, please answer that. And so what I really want to do is I want to talk about things at a sort of higher level to give you all, which is the future of medicine, regardless of what you do, to give you a sense of how to think about different things within the context of what you're doing today or doing tomorrow. Unfortunately, I can't see who's online. Just so I know my audience, how many students do I have in here? Okay. How many non-physician clinicians do I have in here? Okay, good. Do I have any orthopedists in here? Good, that's who I know. I'll pick on that. First rule is always know your audience. Okay, and so, oh, there's all my people on there. You don't see any orthopedists on there, do you? No. Okay. But so what I'm gonna focus on is, which I like to call journey of health. Because we are on a journey, whether it's personal or in our practices or in our careers. And it will look different in the future, because that's what I was asked to do, is sort of look out and see, will it look different? The biggest reason it has to look different is it has to, okay? We can't stay the same. We shouldn't stay the same. We always need to be thinking about, how do we continuously impact that we are truly blessed to serve? And those are the people that entrust their lives, their hopes, and their fears with us every day in different ways. So I'm going to always start out with a question. What product is found to be deficient in its functioning 61% of the time and causes financial hardship when bought by 53% of purchasers? What product? Healthcare. Healthcare, 61% of people with serious illness report one problem while receiving care. 53%, basically, it causes them financial hardship, okay? So we are selling, and I put it in consumer terms, we are selling a product that effectively hurts people, trying to help them, both physiologically and financially, more than 50% of the time, okay? So I'm going to go into a little bit of why this is the way it is. It's not the fault of anyone in this room. It's a fault of lots of different things. And the first one is, who in here this morning woke up and said, I am so excited about what I have to do today? Okay, how come the rest of your hands aren't up? Because we tend to create our narratives in the negative, okay? So the negative narrative is really hard. For example, I'm an internist. I was trained by a medical institution in order to diagnose and treat, in order to do what? Prevent death, okay? What percentage of the time was I successful? 0. Who keeps answering my questions over here? Okay, because I keep going until you miss one, okay? So all of a sudden, I've been trained and spent my whole life focused on something for a purpose where I fail 100% of the time, okay? That is really a depressing story. So how do I change that narrative? How do I think about that differently for me? I think about it differently of saying, what is a positive narrative? What does success look like? For those of you that have gone to business school, you tend to think about the end and work backwards. Well, success in medicine has been whether you live or die, which is the wrong success because you will die. I promise you. Okay. So how do we add value to those we serve through different mechanisms? Because what we want to do, what's the opposite of death? What? You're all wrong. The opposite of death is really a state of non-death. Okay. Life is very different. Okay. I know I'm putting some words together, but really, when you think about giving life, death is a component of life. It's not the opposite. Okay. And so all of a sudden, if I think about it within that context, and I think about how do I help give you life, whether you live or die, or whether you die or not die, all of a sudden, I have created a positive narrative and I've become part of a healing organization. So theme one is change our outlook. How do we create a narrative of success? How do we create life versus just preventing death? So when we talk about value, what is value? Who are my mathematic people in here? Engineers. You can do this as a mathematical as an equation. Value equals quality plus service divided by cost. Okay? Quality being both the usual metrics that we follow. What's your hemoglobin A1C? I've been talking to, so I'm doing a lot of diabetes today. What's your hemoglobin A1C? Mine yesterday was 5.6. I'm very happy. But also, what are consumer reported outcomes? What are consumer reported outcomes? How do you feel? How happy are you? Did you have a good experience? And then you have service. Service is your experiential part, but also how well did I activate and engage you? How well did I help you within the context of your life to think about health and wellness differently? And then everyone in here, I don't care who you are, the denominator is cost, which for an individual is affordability. Okay. So we need to think about that equation. How many people in here said, I'm worried that you're asking me to save money, therefore I can't provide good quality? Who in here has not thought that? Okay, I gotta see what my next slides are. So, oops, I'm going the wrong way. Everyone has thought that. I'm gonna talk about a theory called polarity management, because we need to begin to think about those things very differently and how they go together. So when we talk about all this, you could tell my second theme is, I believe we are a supply versus demand side model. And what do I mean by that? A supply side model is I'm selling a product and all I care about is the supply side, or how easy is it for me? Versus a demand side model is understanding my consumer and selling them what they want to buy in a way they want to buy it. In order to do that, you have to put the person, the patient, the human being, the consumer, which is the word I use because they're the ones that consume our services, as the center. Now, in healthcare today, in our ecosystem, you've got these different groups that are trying to own the consumer, okay? A payer wants to own it, thinks they own the consumer. Why does a payer think they own the consumer?
Because they have more money and power.
They own the, I'm gonna say that differently. I'm glad thing I don't work for an insurance company. Oh, I do. They own the financial risk, okay? So they own the financial risk. So yes, they have that money part. Hospital systems, why do we Sentara think we're the center of the universe? That's a loaded question. Do not answer that. Because we take care of you when you're sick. However, in your total life, what percent of the population ever is in the hospital at one time? Very small. And for the majority of people, how often are you in the, who in here has never been in the hospital for more than a test or something like that? Oh, a lot of you have been hospitalized, but the majority of people tend to not be hospitalized. So a hospital's not the center of the universe. Physicians, why do we think we're the center of the universe? Huh? Because we are. Come here, you're going to give the rest of this talk. Come here, what's your name? But if you're a consumer, we're not the center of the universe. There is nothing more disrespectful to me than when we were going through becoming patient-centered medical home. How dare I say to you that your home is my office? Okay? Yeah, look me in the eye now. Okay. So physicians, yes, we have a tighter relationship, but at the end of the day, we're just a piece of the puzzle. A convener, the sequence of the world, all we're trying to do is put all that stuff together, and then others are like the Amazons or Googles of the world. Why do they think they own you? Because they do. They know more about you than anybody else. The point being is there is no single right answer. And the answer is really, how do all these pieces work together? Hence why I came here, because we've got all those pieces. Hence the relationship with EVMS ODU, because it helps fill in all those pieces. Hence the creation of a School of Public Health, because it begins to fill in all those pieces. Hence the research. That's how it all has to come together. And so what are some of the headwinds? Okay, some of the headwinds we face are financial. They're not insurance driven, they're truly financial. For instance, what country spends the most on healthcare, spends the most on social needs, and has the worst outcomes? Welcome, guys. Okay, this is not a money issue. We all think it's a money issue. It is not a money issue. It's a system design issue. And here are our headwinds. Does anyone believe we're going to get paid more tomorrow than we're getting paid today? No. Then you've got state issues and federal issues going on. The only way that we can fund the tax break that our president wants to give us is you got to create the money somewhere else. You got to get it from somewhere else. And if you feel like part of the overall ecosystem is not doing its end, that's obvious pressure. You could read all the other ones, and these are just some of them, but there are a lot of pressures that are going on, because at the root of it, based on my value equation, what is the driving pressure that's leading to all this? Healthcare is not what? What? Well, healthcare, and I used the word before, this is my test, healthcare is not affordable. Okay? That's how people think about it. Healthcare is not affordable. We have a unit price issue and we have a utilization issue. Okay? Now that is based on some very good reasons. So just going fairly quickly, these are just a bunch of graphs on our government spending that's going over time. And what's going to happen? Our spending is going up, and our government, by the way, when we say government, who is government? Us. When we say government spend, who is that? That is us. Okay, we are our government from a civic standpoint, whether we believe it or not, and we are what government pays because we're taxed. Now, my 17-year-old son told me a long time ago saying, Dad, I know how you think from a giving standpoint. All taxes are forced philanthropy, which is a very interesting way of thinking about it. But when we talk about government, we talk about all that, remember that is us, as well as our dollars that we earn every day. Most consumers' wallets are going to healthcare. This is looking at just what percentage is changing over time of people's, and this is old data, of your individual spend. Healthcare industry outlook, and you all probably don't realize this, but the way we fund healthcare Sure, for those of you that didn't hear me this whole time, I'll start all over. But so there's cost shifting. So what Medicare has done, it underpays and it allows the private sector to overpay. And that's a way to keep, to be honest, our tax dollars down. Now, that's not really true because if you work for EVMS, if you work for Sentara, if you work for Amazon, the people, give Amazon a tax break to allow for insurance. So we're still paying on that side as well because they get a tax break, which is money out of our pockets. And so what is happening is that people are getting older and there are fewer younger people coming into it. So that cost shifting is running into an issue just out of sheer numbers. This is an example of that. If I operated, Dr. Brush, you're below 65, right? Excuse me. Dr. Hooper, you're below 65. Okay, I'm 61. If I got my right knee operated on today at Sentara, they would get reimbursed about $25,000. The minute I turn 65, if I get the left knee, same operation, same everything, when I get it operated on, they only get $12,000. Okay, that's that cost shifting that I'm referring to. Same procedure, same everything, 2 days apart. If I were 64 and then turned 65, you get reimbursed half. Okay, that is just to outline some of the financial component of what's happening, not good or bad. So if there were a single payer system, it would have to be at a higher Medicare rate that it is. And I could tell you that math, but it would balance itself out a little bit. I want to talk about another financial interesting situation that impacts you all. Okay. Average graduating debt from medical school for total education is $243,000, except for those of you that thank you very much for your service who are able to do it that way. Then it's my debt as a taxpayer. Okay. That translates into $5.03 for every PCP visit. Okay, which now is about what, 5% of the total visit? What's an average, $55, whatever, 10%. Okay, where do those dollars go to? Where do those dollars go to? The bank. It's a financial institution model. Debt. Okay, but my point is, and by the way, you have to pay off that debt, so you need to come to me to pay you more in order to pay off that debt, of which money you never see because the bank gets it. Okay, so we have an educational problem of how we finance healthcare that leads to increased costs, which leads to decreased affordability. So you begin to see how all this complexity comes together. That debt does not add any value to care. It lowers value because it increases cost, decreases affordability, and it drives decisions. How does it drive a decision? If you're graduating medical school with $250,000 in debt, what is your first and only decision for you to make? What specialty allows me to pay off this extra mortgage? Okay. If there were no debt, do you think there'd be more or fewer primary care docs? More. Okay. The best thing that I've seen medical schools, I'm not suggesting this for EVMS. Sorry, Bruce. One of the best things that I think we could do for our kids and our society is not allow students to go to school and take on debt. Uh-oh.
Is there any data from the schools that don't?
Yes, it's a great question.
It's turning out lower salary.
So not yet. Okay, I have not seen it. I have not looked at it. Hasn't been going on long enough. Because the first question is, do they go into residencies that are primary care? Then do they go into whatever, and do they charge? I could speak from an N of 1. I got very lucky. My dad and my dead aunt put me through medical school. I inherited some money. Okay. I graduated with no debt. It allowed me to be an internist. It allowed me not to care as much where I went to work for my first job. Okay. That's an N of 1. But I had the freedom because I didn't have any debt. I had no college debt. I had no medical school debt. Went to Vanderbilt. Okay.
While I think having debt or not having debt.
Yep.
I don't know that it overcomes the need in the United States to make as much money as you can and have all the practice
Yeah.
of whatever.
Yeah. So no, I completely hear you because we had this conversation at lunch before you came in. And everyone shut your eyes. Okay. Everyone shut your eyes. Because I'm going to ask you a question that I can't have anyone else see the answer to. How many of you went into medicine because you were thinking about it as a kid to make as much money as you could? Okay, you could open your eyes now. No one raised their hand. Okay, some of you are liars, but okay. My point being is, and then I'm going to move on, people that go into health sciences tend to be service oriented. They become blurred over time with the American dream. And what's the American dream? What's the American dream? As you see it. Yeah.
Well, the American dream is have a comfortable life.
Yeah, make as much money. I'm going to translate it differently. You're being nice. To make as much money as you can. Okay, that because the American dream is really to get the closest parking place to the front of the store. So now we got to think about everything within human dynamics. And now I'm going to talk about a theory called polarity management. Has anyone heard of that theory? Okay, Dr. Hooper has, I know. What does 2 plus 2 equal? 4. 2 plus 2 equals 4. Are there any other correct answers? This is not a trick question. Are there any other correct answers? No. In order to equal the number 8, using whole numbers, including zeros, 2 numbers, how many combinations are there to get to the number 8? 0 plus 8, 1 plus 7, 2 plus 6, 3 plus 5, 4 plus 4. 5. Are any of those, you're welcome, you can phone a friend, are any of those better, are one of those better than the other? They're all equally as good. So it's a more complicated question, but they're all equally as good. Okay, where's my pulmonologist in here? Where do you go? Hooper. So Dr. Hooper, in order to live, you have to breathe. What are the 2 components of breathing?
Oxygen coming in, carbon dioxide.
Side going out, inspiration and expiration. Which one's more important? I asked you a question. Which one's more important?
They're equal.
They're not equal. Because if I asked you to run out of here, which would you want to go up? Inspiration. And then if I said go to sleep immediately, what would you want to happen? Expiration. Because you want your inspirations to go down to retain CO2, right? And where did I trap Mike? I asked the wrong question. He still tried to answer it. Okay. The right question is you've got 2 equally as important things that change over time, depending on the situation, that go in opposite directions and are intradependent on each other. So the question that our body does is not answering which one is more important. It answers the question of how do you manage the complexity of 2 things that are both important, go in opposite directions, are interdependent on each other. Okay? We ask the wrong questions. What do we always try to do? We try, not always, but for the most part, what do we try to do? We try to simplify things to that simple 2 plus 2 question. No matter what we do, that's what we do. Don't do that. Ask the right question. And if you have to manage a complex question, frame it as a complex question. Don't try to get to the or, try to get to the end. How do I manage inspiration and expiration if the fire alarm goes off? How do I manage inspiration and expiration if I need to go to sleep for a sleep study? Okay, how do I do all that? And so now I'm going to pose a bunch of high-level sociologic issues in this country that points to the fact we don't do polarity management. Is healthcare a privilege or a right? It's a right. How has it been deemed a right in this country? What? What regulation? EMTALA. EMTALA has made healthcare a right in this country. If I went out to the street corner, and I used to do this all the time, or if I were talking to the Knights of Columbus or whomever, and I said, close your eyes, who believes healthcare is a right? Who believes healthcare is a privilege? Basic healthcare being a right, okay? Guess what answer I get every time? What? No? Right, privilege. 50-50. Every time. Meaning we as a society have not decided if we're going to believe healthcare is a privilege or a right. Obviously, I believe it's a right, okay? But we as a society have not agreed on that. We haven't, whether right or wrong, okay? And why have we not agreed on it? What's our Constitution based off of? What? Why was our Constitution created? In order to get out of the tyranny of King George, and it's based on human individual rights, okay? So when you talk about individualism versus a common good, our Constitution was based on individual rights, privilege, okay? So we have this polarity from a societal standpoint. So the question isn't, is it a right or a privilege? Is there individualism or common good? It's a matter of how do you manage the complexity that half of us think one way and half of us think another, and then we have rules that force it one way when half the people don't agree, when we are paying it in our taxes, okay? So theme number 3 is live in that complexity. Live in it, focus on how do you manage the complexity. How do we not try to get to one answer because we can't? Conundrum, whatever you want to call it. What is said, now on a human level, what is said versus what is heard? Okay? I guarantee you what you all are hearing me say is very different than what I am thinking I'm saying. When you communicate, who owns the speaking? The communicator or the communicatee? Dr. Hooper? The communicator. Who owns the hearing? The communicator or the communicatee? No. The communicator. If you want to communicate with somebody, you own both ends of it because you're the one wanting to communicate. Okay? When I am sharing this today, you hear me saying theme 1, theme 2, theme 3. I'm asking questions. Why am I doing that? To make sure you're hearing what at least I'm trying to say. Okay? As communicators, no matter what you do, you own both ends of it. And what's a great way to find out if you've communicated well? Exactly, speak back technique. Hey, Mike, what did you just hear me say? That's not what I thought I said. Let me frame it differently. Right? See, you heard me right. Okay, so what is said versus what is heard. The next one is fear versus critical thinking. COVID is a perfect example of this. Are we lizards, as you said, or not? Are we animals or not? Yes. Okay. Therefore, what's our strongest physiologic mechanism? Fight or flight. What drives that mechanism? What emotion drives that mechanism? The answer is on the slide. Okay. Fear. Okay. How do we overcome our fears? Or how do we work through something when we're not quite sure, which stimulates fear? We use critical thinking, okay? Are we born with critical thinking? No. How do we get our critical thinking? School, taught, and experiences. What is lacking in our education system today? The teaching of, you definitely don't have experience. Yeah, so I saw a great video. How many grades of school do we have? Kindergarten through 12th grade. What, 12, right? Well, so what do we call year one? Kindergarten. What do we call year two? First grade. How many of our words not only have a number, but a word attached to it? 12 is a dozen. And someone says, well, there are no others. Yes, there are. None equals zero. So that just gets to, I don't know why I brought that up, but okay. So critical theory. So we have to live in a world that we all know physiologically fear drives us, and we need to have critical thinking. Okay, and understanding that critical thinking is not really taught much anymore. Okay, logic tests, all those type of things. Who took classes in college on logic? Yeah, a lot of us did. They were a lot of fun. Okay, we were talking about this at lunch. Liberal arts tends to teach you how to think critically. However, liberal arts, we don't like hiring people from liberal arts because they don't have a trade. So we have left our best thinkers out of our workforce. Okay, I'm just bringing up the complexity we live in, not right or wrong. So then we have consumer dynamics. We've got a lot of myths. Loyalty trumps convenience. Nope. Reality, convenience often wins. Myths, costs aren't a key factor for consumers. Reality, many consumers care about understanding costs. And if I really pushed you all, I guarantee you, many of us would say, this doesn't pertain to me because my patient loves me. They do love you, but not as much as convenience and cost. Because guess what? Quality is a given. They assume they're getting quality. Okay? Myth, consumers rely primarily on their doctors for information. Oh, no, 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 no. Oh, no, 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 no. What do they rely on for information the most? Dr. Google. What do they rely on even more? Whoever told them the last thing. Okay? That's human nature. Don't fight human nature. You don't win. Because you're dealing with human nature. You're not dealing with logic. Never try to put logical on an illogical situation, logic on an illogical situation. Tech companies are entering the healthcare market and threaten to displace legacy players. We're all worried we're going to be put out of business by AI. That is just not true. Tech company, $5.4 trillion business. All they want to do is get a piece of your action. Okay? They are not trying to displace us. They don't, how many times have they tried to get into our space and said, this is crazy? You all do crazy stuff. It's too hard. Amazon got out, Oak Street got out. It's just too hard. They just want a piece of it. There is a silver bullet. I said something that offended somebody. They're leaving now. There's a silver bullet solution to the challenge of consumerism. No, there is no silver bullet. Experience requires personalization in each step of the journey. So at the end of the day, those of us that are trying to think of it at this level, we're trying to think of as mass personalization. Because the hard part about doing something is to scale it, is that you got to start doing everything the same. In medicine, we are in the situation where we're trying to do mass personalization. Cancer, we're trying to do precision medicine. Okay, that's just an example of mass personalization. So I think later I talk about it. If not, I'll come back to it. So I now want to talk about, I want to be apolitical or atribal. I want to talk about what's going on up in DC. Okay, a lot of interesting stuff, but I do want to share, oops, I want too many. Okay. Am I going forward or backwards? I'm going forwards. I'm so sorry, guys. This tells you I don't really pay much attention to slides. Consumer dynamics, okay. So HHS Secretary RFK, okay, he was given, whether he does them or not, he was given 3 dictums. Number 1, clean up the corruption in our government, in our healthcare agencies. Okay, whether we agree there is or not, that's what he was told what to do. Okay, we see that playing out at the NIH. I'm not calling it corruption, but we're seeing that thinking. That's what was asked. Return those agencies to the rich tradition of gold standard evidence-based medicine. What has driven that in the past 5 years, where we had to go on things that were not necessarily purely played out? COVID. Okay, no one did the critical thinking to say, no shit, we don't have evidence-based. Oh, sorry, because we're dealing with a brand new epidemic. Okay, so the thought is, and also our research, except for what Dr. Brush and Cindy are doing, is really based on, does something work, not if it gives value, or not if it doesn't harm. Okay, so the way we approve drugs and the way we approve things is evidence-based for the evidence they are looking at, not for big evidence. Okay, how does Europe do it? Interestingly enough, do things come to market quicker or slower in Europe? Much quicker. Okay, but what do they do very well? They do post-marketing surveillance. And they'll say, oops, we shouldn't have done that, and they pull it. If we did post-marketing surveillance and pull it, that means we were trying to hurt people. Okay, it's a different way of thinking about it. So if you want speed, you got to live in that polarity and then have a mechanism to pull things back. If you want everything to be perfect, you got to wait for the data, but you can't do that because you got to take care of people. Make America healthy again by ending chronic disease epidemic, which is a very interesting conundrum in my mind from what we hear, because we are shifting from acute care situations to chronic care situations. Who in here is against that? Okay. So that's what those things are. Now, this is all wrapped around in tribal language. It's all wrapped around in our fight or flight mechanisms. It's all wrapped around in the logic of other people is not the same as mine. Okay. It's all wrapped in that. But those aren't facts per se. Those are sound bites. What about Dr. Oz? This one's really interesting to me. In 2018, he came out saying he wanted Medicare Advantage for all. Okay, what would Medicare Advantage for all mean? A single payer system. Now, do we think the Republicans would ever believe in a single payer system? Okay, no. However, the guy appointed believes in a single payer system. Okay, and why is that? No matter how you do the math, if you have healthcare as a right, as a societal right, there's only one way to do this. Okay, now you could still privatize it, how it's done, whatever. What percent is already that we pay for healthcare now in the country with our taxes? What percent? You know these ain't. No. No. 70%. 70% is already publicly funded. Medicare, Medicaid, CHIP, okay, VA, private pay, ACA, Obamacare, 70%, you know, it's funded. Commercial insurance is funded with tax breaks. So we, in fact, are already, as a country, in a situation where we're paying for 70% anyway. So a single payer system, we're at a 0.7 single payer system now. We just haven't set it up that way. A fee-for-service model, which has created dysfunction, okay? So Dr. Oz also believes in fee-for-value, okay? Wants to pay on that value equation I talked about earlier. How many people are against that in here that have said fee-for-service models are the bane to our existence? Okay, they're not, because they were created on a relative value unit done by the AMA and our medical societies. It just turned into a timestamp. Okay, so the person in charge of this is not is not trying to privatize everything, and he is not, and he believes in value, as the equation I talked about earlier. Key themes: healthcare was not a campaign priority on the campaign trail. However, what was a campaign priority? Not immigration. Pick another one. What did Trump do in his first tenure? Tax cuts. What expire next year? Those tax cuts he put in place. Big priority is continuing those tax cuts. Okay, only two ways to do that: print more money, tax people more, or take it out of somewhere else. So we're seeing a lot of pressure on healthcare, not because healthcare being a theme, but because taxes are a bigger theme. Okay, robust and free competition. Huge belief that competition helps hold down costs. Conundrum: how do you deal with competition in a right scenario? Competition requires the ability for me to decide to buy something or not. So until we let people die on our doorsteps of our emergency rooms, that becomes very hard. Patient choice. Who's against patient choice? Okay. Clinician autonomy. Avoid irrational reimbursement schemes. Reduce regulatory compliance burdens. That's what we're pushing for a lot. If you want to cut us down, so in Sentara, we have an insurance side and we have a care delivery side. What percent of the dollar is just paying and billing ourselves? 12 cents on the dollar. Okay. We would do better just to say, we're not going to bill or collect from each other. Okay. You could think about that at a broad scale. Okay. And so getting rid of the regulatory compliance and all these billing intricacies creates real dollars that can go to care. Emphasis for rural care. Okay. Rural care is a distribution model issue. How do I distribute care to rural areas? Move away from restrictive and complicated approaches to value-based approaches. All that is doing, by the way, and I'm a value-based care guy, all that is pushing down the risk to the clinicians. Okay, I'm not saying that's bad. You're the place that owns driving the cost. You should own the risk. So each of us become that insurance company you hate so much. Okay, because at the end of the day, our pens or our keystrokes is what drive costs. We should own that risk in a financial model, or not worry about it and have socialized medicine, which we're not, based on our Constitution, King George, we can't do that. Okay, unleash innovation. Absolutely. However, what's the problem with innovation? Okay, it's expensive, but we got plenty of cash that come into it. There aren't 2,000 great ideas or 2,000 great leadership teams. Okay, there's a lot of chaff you got to peel through to see what's real or not. The majority of my emails every day is someone trying to sell me something. Innovation, all really cool. Okay, and we in healthcare have something called the shiny object syndrome. What's that? Ooh, shiny object, I want that. Okay, so unleash innovation, transparency. We are not transparent at all in any parts of our healthcare ecosystem. I had to make the decision of whether to release my chart immediately to a patient. Do you know the crap I got from physicians? Unbelievable. Wait a second. You're telling me that I should not be given patient data to the owner of that person until you, mighty God, get to see it first. Well, they'll get confused. So tell them not to look at it. How dare us say that your information is not yours? Why should you not have access to it immediately? By the way, Dr. Hooper, that transparency has done what to quality? By allowing you to see your chart quickly. What has it done for quality? Improved it. Why? Who cares about your results more than you do? Nobody. When I don't get back with you, or if I'm going to miss something, who's going to dog me? You, because you see it. Okay? So transparency is a huge one. The Transparency Act is getting right at this. Reduce fraud, waste, and abuse makes sense, lots of dollars there. So what are some future model designs? I didn't wear my watch. I'm trying to be quick. Okay. Acute care versus chronic care prevention. This country there is nowhere in the world I would rather get acutely ill than in the United States. Nowhere I'd rather be in a car wreck. Nowhere I'd rather have an MI or stroke than in the United States. There is nowhere worse in the world to get old. I'm going to let that sink in. We're based on individualism. We want everything when we want it, and we want the best when we want that. And that is where we have focused all our attention, okay? Versus chronic care and prevention, and to me, that's aging, okay? That's aging. We do that incredibly poorly because we have focused our attention on the acute care side. How do we manage that conundrum? How do we live in that complexity? And when I told you what, the administration is focused on, that chronic care, it is getting at this a little bit. They don't know it, but it's getting at that underlying polarity issue of acute care versus chronic care. Primary care services versus primary care physicians versus specialists, okay? Our model right now is a primary care physician-driven model. Not sure that's right, okay? Why does a primary care physician have to order your mammogram? How rude is that? Okay? Why is that? Oh, because we got to make sure we see the results. I just taught you how you're going to get the results immediately. I mean, how presumptuous of us to say that primary care services, which I can solve in a public health model, let's not call it public health, let's call it a primary services solution model, versus primary care physicians who want to take care of people. But right now, who in here is in family medicine? Okay. I'm an internist. Who in here is an internist? What have we become treating in public? We have become, because it's a centered model, we have become a lot of times a triage service. Okay? You didn't go to medical school to become a triage service. You want to treat and diagnose, take care of people. Okay? So we really need to think about that. Specialists. Any specialist I ask, when I ask them, what % of your business do you see you shouldn't be seeing? What percentage did they give me? Across the board, which makes it right. 30%, 30 to 50, 40%, whatever, could be more. The point is, they're seeing things that shouldn't be sent to them in a triage model, okay, that we could solve for differently. What % of my patients that I saw should have seen a specialist that I never referred to? Probably about 10 to 15%. So not only do we over-refer, we under-refer. We talked about this at lunch, and wouldn't it be great? You have the ability, and how does a specialist see a patient today? What? Get consulted, a referral. What a stupid model. Okay, we've got access to all the data now. Why would a nephrologist be looking at that data for a population and say, these are the people I need to see? Who called it auto consulting? Okay, no, it's called treatment. You know sugars, you see what medicines they're on. Computers can literally tell you, here's the list of people you need to go see today. We're on this primary care centric model, which is referral based. Rheumatology, same thing. Dermatology, where's my dermatologist over here, right? You wish you were, right? You'd be the one with the masseuse on your back right now, right? Sorry about that. That was from what TV show? I forgot. So we need to be thinking about this, physiologic versus psychologic. How many of you write, where are my medical students? When you present a case, what's the first line of your HPI? Yep. Diabetes, whatever, right. How did he just do it? He presented his person as a physiologic state. You didn't say, my patient that lives by themselves has an IQ of, whatever it might be, has these life issues, diseases of life, who happens to present with this complaint. Okay. We in medicine have put everyone as a physiologic situation versus a psychologic situation. We don't look at people as their human nature. We think about that second, but we think about their disease state first versus their diseases of life. Put that line right in between them, okay? So we really need to be thinking about, how do we do both of these? How do we think of that human activation and engagement? How do I work with you as John Brush, who happens to have whatever you have, versus someone who has this, who happens to be John Brush? Okay, you didn't even open up with their name. Hey, this is John, who blah, 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 blah. This is Mary, okay, who wants to be referred as. Okay, my point is that these are things that we don't even realize we're doing or that we're thinking, because we were trained to do it this way, okay? I love talking to those that train and are being trained to think about it differently. Activation and engagement versus education and didactic thinking. We are very good. So when I went back to business school, I'll never forget when I came home for the first time, I told my wife, I said, this sucks. They are not teaching me anything. And why was that? Because I was very used to this. Me feeding you information, spooning it to you, and asking you to regurgitate it. Business school is very different. It's a team-based approach. And so it's like, I had to work with these other people most of the time. I never had any classes. By the second session, I realized, second week, oh my gosh, this is a much better way of learning. We do not educate ourselves well in medicine. It's a very different model. Okay. Value-based care versus value-based payment. That's just a thing on the value-based care. We tend to interchange those. They're very different. Think about value-based care, then we figure out how to pay for that, the payment models, okay? They're not one and the same. Full risk is not the only way to deliver value-based care. There are lots of ways, and you got to think about the payment models. And so thank you, Dr. Hooper, for this slide. This gets to my model of the historical care of putting the physician in the center, where you've got an evolving model where you put the care team in the middle. My argument is, for all you smart people, figure this right-hand model out, taking out the physician. How would you solve this problem? What would your care model look like if tomorrow I waved a wand and 50% of you became science teachers? How do we solve our problem if we had fewer physicians, not how to create more physicians? Okay? And so that would become a very elaborate triage model, where things would go into a triage model that is helped and done by algorithms and a lot of tools that we have now. And then you would be pushed out to your comic, to where you needed to go. Okay? Because at the top, you sort of have it here, you put on top of that, because every person calls in trying to solve what? No one calls saying, I really want a gatekeeper. I really want someone. They call in saying, my chest hurts. I'm having shortness of breath. My left arm hurts. They call in with a problem. They want a problem solved. Okay? So think about those evolving care models on the right. Medicine has advanced in lots of places. What's very interesting, technology has done what to healthcare costs over the years? Only industry where technology has increased healthcare costs, have increased costs. We're getting to AI. I'm not going to talk about AI, but obviously that is area. Physician workforce shortage. It's what I just talked about. Estimates this big a shortage. It's not at the medical school level. It's at what level? Residency. More applications for medical school than ever. Okay. People want to be physicians. They're driven to do that work. The issue is residency slots. Advanced practice clinicians are growing, okay? The key takeaway here is let's not fight this. Let's embrace it. Let's figure out how to make it work, okay? Why do APPs hate working for big health systems? These are treated as physician extenders versus their own profession. They are a profession. Okay? If they're just there to make a doctor's life easier, that doesn't work. It's demeaning. Okay? So we got to think about all these people and how do we help? The role of academics, okay? Academics is critical to all this. Critical. You account for 3.5% of use hospitals, but provide 11% of inpatient care. So it's about a 3-to-1 ratio, okay? Workforce development. You are the creators of the workforce. Allied health, physicians, nurses. You are it. And you own the responsibility of the evolution and improvement of healthcare delivery. Because what is so much harder than teaching you a way to do something? Unteaching you how to do that. Okay? So this is ground zero. This is where it all has to occur. So what are the role of academics? New content, new way of thinking, new models, new designs. And also, we've got to get away from, and some of this is regulatory, a time-based model, okay? Why does medical school have to be 4 years? Why does internal medicine residency have to be 3 years? Okay? How does baseball do it? Who's a baseball fan? Look at Brooke looking the other way. How does baseball do it based on what? When you're ready. How do they judge when you're ready? Watch you. Stats. Okay? You can graduate high school and end up playing for the Mets. Or the Braves right now, maybe. But my point is, it's based on how well you do. You could spend your entire life in the minor leagues. It is not time-based. It is skill-based. Why are we not doing medical education the same way? Now, you all are, interestingly enough, thinking about shorter programs, high school, so on and so forth. But think about that. New types of workforce. Family are the caregivers of the future. They're half our workforce now. They have zero training. How do we think about that? Research, benefit versus harm. So I want to leave you, as the audience is leaving me, the big thing I wanted to do today is just get you to think a little bit differently. Not to agree with everything I've said, but my favorite quote from Oliver Wendell Holmes is, "A mind stretched by a new idea never returns to its original shape." Y'all have a great day.